Hello and welcome back to Political Storm. I'm your host, Sean Storm. We're going to continue on with the series on healthcare that we started last episode. Before we do, I do want to reiterate that everything stated here is my opinion only. I am a member of the Reform Party, but I am not speaking for the party at this time. Further, I want to give you a little bit of my bona fides, just so that you understand that I'm not going to ever call myself an expert on anything. I'm kind of more of a jack of all trades, but I have been a director in healthcare for 12 years now, specifically in the administrative side of revenue cycle. I am revenue cycle management director for a rural acute care hospital. So with that said, let me go ahead and get into this. With our last episode, we discussed why healthcare plans from the Democrat and Republican side are failing and will fail, especially, in my opinion, if we switch to a single payer source, how that would be really problematic for people on the, what we call middle class and up, because of not only absorbing that cost, but not having ways to fight anything that happens if we don't like it. Because if all you have is the one source, you can't threaten to go somewhere else. There's no choice. With that said, I also want to remind you that the problem that I see with both parties working on this is they attack it from just looking at insurance. And if you remember in the last episode, I talked about the three aspects of the problem in healthcare cost. You have the insurance that everybody's focusing on, but you also have the manufacturing side, which is both pharmaceuticals and the durable medical goods and things of that sort. Then you have the provider side of things, which, believe it or not, and it's not going to really surprise anybody, I don't think, is actually mostly due to administration costs. So let's start with the pharmaceutical side. One of the big issues that I see, my wife is a type 1 diabetic, and if we didn't have insurance, we'd be paying close to $380, I think, or $520 for a vial of insulin that she has to have every month to survive, to live. She is a very brittle type 1 diabetic, and she would fade really quickly if she didn't have access to her insulin. With this being an issue, what I think most people don't understand is you'll always hear, well, it only costs $3 or $4 to make a vial of insulin. And here I am telling you that without insurance, she'd be paying about $500. That's more than 1,000 times the cost of manufacturing a vial for $4. But that's not exactly accurate, because yes, it costs $4 to make one vial now. But that very first vial, the cost of making it in today's money, last time I looked, it was about $28.4 million worth of time, manpower, research, getting it through the testing, marketing it, things of that sort. And companies deserve to be able to make a profit, but not at the cost of lives. So this part to take care of the pharmaceutical is kind of a two-parter. The first one is dealing with patents, because a big issue that we run into is how long patents are and how easy it is to get extensions on patents for very minute changes. The patents on the medical side of things is 20 years. Now, it can take 10 years to go from, I have an idea, here's the formula, I'm going to put a patent on it. Okay, let's start manufacturing it, see how it works. Let's start testing it. Now let's go to the FDA process. It can take 5 to 10 years to go through that entire process. So then they only have 10 to 15 years of patent left when they go to market. But here's the thing. Now, what does it mean when they have a patent is that you can't have generics. Other companies can't go, oh, hey, that's a really good product. Let's make it too. And since they did all the work for it, we're going to make the same thing, but we don't have to do all the research and put all that time into it, so we could sell it a lot cheaper off the cuff. Well, companies then found the loophole of, you know what, that pill is about to go off patent in about 2 years, so we're at year 18 of the patent. Let's change what we use to hold it together. Not the medication itself, but the binder we use. We're going to change that because we're going to say we found that it has some side effects that we don't like. So we're going to use something that has less side effects or no side effects. And they make a change to the filler. And they renew the patent. Now that renewal, thankfully, isn't for another 20 years. It's an extension of 8 years. But still, that's ridiculous. Another common change that they make is they do more research as time goes on, looking at effectiveness of doses, and they start playing with the dosage. If they can make a big enough change in the dosage recommendation, they can request a patent extension on that as well. So my thoughts on this end is patents from when they apply are good timelessly through the research phase and getting it through FDA. But once it has FDA approval and the day after it goes on market, that patent's good for 5 years. No extensions whatsoever. After 5 years, it then can go to generic. And that will cut out a long period of time of a very much needed drug being uber expensive because you have no generics to switch to. And it also creates some competition once generics are available because the original, most people feel most comfortable with it. But if it's overpriced compared to the generics, then it's going to come down a little bit to get close to that generic price. But it'll never dip below it usually. With that said, we then go to the second piece on the pharmaceutical side, and that is directly tying to these life-saving ones like heart medications, insulin, things of that sort. Putting a price cap on it. If a manufacturer can prove that within that 5-year period that they have, that they cannot possibly just make up their research costs, but can't start turning a profit with their income of expected patients for their product in that 5-year period, they cannot charge more than $100 per month for their product. I honestly think that would be a very fair amount. And it's still fairly high for many people, but a lot of people feel like I'll pay $100 instead of the $250 I'm paying now. And I think we'd find that not many medications would ever be able to get above that $100 for life-saving medication. If it's an antibiotic and things like that, because you have so many choices and things, that's different. It's able to be priced as it is. But for true life-saving medications, one that we know are required for people to live, cannot be charging more than $100 a month for. On top of that, and I know that that's regulation, which a lot of people don't like. Again, understand, I'm not saying my plan is perfect. I am not that arrogant. I will say that I believe that my plan fits within the schema that the formation that we're working in now by keeping a fairly open market, but with regulations. It allows for multiple insurances. It allows for drug companies to keep working the way they do, only narrowing down their patents and saying, hey, you can't charge $500 for something that now costs you $4 or $5 to make and somebody has to have to live. I'm going to move to the insurance side of things, and more than likely we'll switch to the provider side in my next episode, because I don't want this to turn into a 30-minute episode for anyone. I try to keep them around 15, 16 minutes. With insurances, first and foremost, all pre-existing conditions need to stay covered. You can't sit there and say, no, we're not going to cover a pre-existing condition for a year. That, as a society, I think we finally come to the realization that that is completely unacceptable. It's dirty pool. On top of that, insurance companies must allow, if you switch jobs and your new job has a different insurance, you don't have to now wait 30 days from hire and then the next month. It starts the next month. And know that it can be painful. You got something happening. You have a severe accident, injury, something like that, where it's helpful to have insurance the very day that you start. But a lot of policies and things start on the first of the month. So an allowance has to be made there, unfortunately. With that said, insurance companies also, in pricing, if they are negotiating with an employer for employees and such, their rates after the employer pays 1/3 of the premium for the month, the employee's piece cannot be more expensive than 1/3 of their paycheck. I mean, that's huge in most households. I know that whenever I was working and making only $40,000-$50,000 a year, losing $200-$300 for insurance, that almost killed us. We had to live in a 2-bedroom house for a family of 4, a young girl and a young son, and afford both our vehicles because we had to work on separate ends of town at the same time, and giving up $200-$300 of a paycheck, even though my wife was working too and she didn't have to have insurance on hers, that hurt a lot. So there, a lot of insurance have step plans. I would completely do away with the what I call junk insurances, and it's known that way in the industry, of what's called low premium, high deductibles, because those are truly only good for emergency, or not. Those are only good for healthy people, basically. They're made to cover major accidents and things of that sort. You have to pay $8,000 to $10,000 before insurance starts picking up. And that doesn't do anybody any good, especially people that are struggling for insurance, because the poorest among us are also some of the unhealthiest, because they don't go in to see a doctor on a regular basis. But as soon as they're diagnosed with anything, then the high deductible plans do them no good whatsoever until they spend $10,000 in medical costs. And there, if you think that $30,000-$40,000 a year, you're talking about 1/4 of their entire yearly income before insurance starts covering. So 1/3 of a paycheck, not their monthly income, but a paycheck, it is the most top end that an insurance can ask for a premium from the employee for their lowest effective plan, I should say. Then, most of them have tiers. My personal insurance through my employer, which is, I love my employer, has 2 plans. They have, they actually have 3. One is one of the junk plans I was telling you about. The next one is really a mid-level. The deductible hits at $6,000 for the individual. It does cover your medication to a point, gives you a discount on it, but doesn't actually add to it. But your medication does count towards your deductible. Where my plan is more around $3,000, an 80-20 plan traditional, but my medication doesn't count towards that $3,000. With that said, we want to make it to where insurance companies cannot require as many prior authorizations. For those of you that don't know what a prior authorization is, it's exactly what it sounds like. You have to ask, or your provider has to ask for permission for you to have the procedure that they're asking for. And your insurance has the right to turn it down. What kills me about these prior authorizations is that you're constantly being told, all the right and decisions of your treatment are between you and your doctor. Well, that's not the case if your insurance isn't going to pay for it. A good example is CT scans of joints and things like that. I know of cases where someone has hurt their elbow, and the doctor examines it, gets an x-ray, and they can't really tell what's going on there, so they want a more detailed scan through the CT scan. And they order one, and the insurance company comes back with, no, you need to do 6 weeks of physical therapy first. Do that first, and if the patient's still having issues, then we'll okay the CT. And, a person that's in their late 20s, early 30s, and they're in that much pain, the doctor doesn't want to risk going through physical therapy and causing more damage before they can see what the problem is. So my thoughts on this is reduce the number of of prior authorizations required. Instead, make it to where it's a step process for very common procedures and such, like a CT scan, saying that unless you can prove XYZ, then before you can do a CT scan, you have to go through 4 weeks of physical therapy. Otherwise, you have to contact the insurance company to go through what's called a peer-to-peer review, where the doctor basically has to speak with the insurance company and convince them that this is the best course. That way, the treatment plan does stay with you and your doctor. Unless the doctor's not wanting to follow that step process, then it turns into more of a, well, do you want to pay for it, risk paying for it out of pocket? Do you want to wait a little bit for me to speak with your insurance company and get the permission to go ahead and get them pay for it? Or do you want to try this physical therapy for 4 weeks? You're given choices on how to handle it, but it allows things to move faster. Right now, prior authorizations, depending on the size of facility, of course, and what insurances they're working on, can take anywhere from 2 days to 14 days if there's no issues whatsoever. If there are, and it gets denied and things, it can take up to, I've had them take up to 30 days to get approval. One of the ones that we have had trouble with that on, it was for a life-saving procedure. What my facility ended up doing is going ahead and doing the procedure and fighting with the insurance company for the prior auth retro after the fact. And that one always kills me. I cannot tell you how many times I've heard the conversation on the phone with insurance companies. Well, prior auth means prior to the procedure being done, not after the fact. That's why it's prior. But they fought us so hard and we didn't want to risk the patient. So yeah, that's where I'm going to leave off. I do have 1 or 2 other aspects on the insurance side that we'll discuss on the next episode. Please join me again, and thank you for your time.